In this session, we are going to discuss here another topic regarding the osteology of the head and neck. It is temporal fossa. Now, temporal fossa is the most prominent part of your lateral side of the skull. If you will actually be watching here, you see when you have removed the skin from here, clean the superficial fascia on the lateral side of the skull and cut the deep fascia. Deep fascia means deep fascia is not present in the front, or you say in the anterior aspect of your head, that is called the face, but it is present very much here on the lateral side of your head here. And this is the same deep cervical fascia which has enclosed the entire neck here like an envelope, and it was fused here to the lower part of the chin and the inferior part of the body of mandible, up to the angle of the mandible, then to the mastoid process, up to the knuckle line, that is called the superior knuckle line, and the occipital protuberance here. It was just circumferentially, it was actually attached to that and waiting for permission to get onto the head now. This was the cervical fascia, that was called the deep cervical fascia. But you see, when it comes to enclose the head region and the face region, it was not allowed to come. But here in the lateral side, it was allowed to come surely, and when it was actually passing here onto the lateral side of your head, here you know that parotid gland comes, because parotid gland is located here on the lateral side of the head, just over the ramus of the mandible. And this deep cervical fascia, after its attachment to the inferior part of the body of the mandible, this deep cervical fascia actually comes here on the lateral side of the head region, but is not actually coming to cover superficially the parotid gland, but it comes to split here into the two laminae or the two layers to enclose the entire parotid gland. So, it will be, in fact, the parotid gland will be totally capsulated by this deep cervical fascia's onslaught, onward extension there. And this time, because it is not cervical, it is not the neck, but it is the continuation of the same cervical fascia, the deep cervical fascia. But here you will call it the parotid fascia, especially it is a superficial layer which is just under the skin and superficial fascia, and this is a unyielding and it is very tough here. This is called the parotid fascia. But you see, the parotid fascia will not stop here, it will continue now, and it will continue now means it will not remain here localized here to your face region lateral side, but it will try to come over the scalp now. And scalp means this, after splitting into two and enclosing totally or investing totally the parotid gland, because it is giving actually the false capsule to the parotid gland. Parotid gland its own mesenchymal thickening, its own capsule, that is called its true capsule, but the false capsule has been given by this deep cervical fascia's onward continuation, and here this deep cervical fascia is actually called investing fascia also. This is deep cervical fascia, this outer layer which you are in fact discussing right now, it is called investing fascia, because it is investing whatever comes its way. And here the parotid gland actually has been encountered by him, and it will split and will enclose the entire parotid gland, and a superficial tight layer actually is called the parotid fascia. And this parotid fascia, it will stop again and will get fused here to the lower border of the zygomatic arch. Zygomatic arch has been in fact shown here to show you the zygomatic arch. So, it will be here. So, we know that here is the parotid gland splitting in and coming up here, again it becomes single, and this single layer of deep cervical fascia's outer layer, whose name is investing fascia, previously this segment was called the parotid fascia, it will stop here. Stop means it will actually be getting fused with the lower border of the zygomatic arch. So, from the lower border of the inferior border of the body of mandible up to the lower border of the zygomatic arch, this whole layer is called, or this segment is called the parotid fascia. But above that now, it will now come up. When it is coming up now, that means when it is coming up, you can feel your zygomatic arch here, and when it is actually coming up, so you see this is coming up now, and when it is coming up, so you see that it is now covering the lateral aspect of your side of your head now, the lateral aspect. So, lateral aspect is being covered by this. So, this parotid fascia, which is in fact is already we discussed here, that from the lower border of the body of the mandible and up to the lower border of the zygomatic arch, this is called the parotid fascia because it is covering the parotid gland. But after that, this parotid fascia was name of the parotid fascia, but later on, because here is not a parotid region, it is a temporal region. So, that fascia will be called as the temporal fascia. It is the same investing fascia as continuation. So, various segments in fact will be called here. So, this will be right from here the superior border, so right from here, the superior or say inferior border of the zygomatic arch onward, it will now cover the cover all these bones which are actually present there, and all these bones you have already noted here. On the lateral side we have got the 4 bones, and they are united with each other, are getting the sutures with each other, and H-like sutures, H-shaped sutures here. You see this is here, is coming here, on the back side is coming, this is a ischiumous part of a temporal bone. So, this is a ischiumous part of a temporal bone is coming from behind, this is a temporal bone, ischiumous part. And you know that when this ischiumous part of temporal bone is coming from here, it will come across a pair of, you see that bones here. Above, here will be the parietal bone, and below there will be the sphenoid bone. This is called the greater wing of sphenoid. So, greater wing of sphenoid and parietal bone, they are having a suture with each other. This is called the sphenoparietal suture. And this sphenoparietal suture means these are the 2 bones here, and behind there this ischiumous part of temporal bone, which will actually make a suture with these bones which are already sutured with each other. This is ischiumous, and this is a suture created here, that is called the ischiumous suture. And similarly, anteriorly there is coming here bone, this is called the frontal bone. This is frontal bone, and frontal bone is actually making another suture with the pair of bone, this is the parietal and the sphenoid. So, we have got one vertical limb of the H, another vertical limb of the H, united by means of sphenoparietal suture, that is the horizontal limb. So, H-shaped suture has been created, and that is spot where the 4 bones are meeting with each other in some pattern. This area is the weakest area. You see, this is the weakest area over the temple, that is called the pterion, and that is called the pterion, and the pterion is present here. And underneath the pterion, you see that here sometimes you see like a sports injury or fall from the bike or any injury. On the lateral side of this area is called the temporal zone area, where there is a pterion zone. This is a pterion spot here, where all these 4 bones are meeting with each other through that H-shaped suture. Underlying there will be a very important artery, that is called the anterior division of middle meningeal artery. So, usually this artery, as a result of the impact injury or a direct injury, it can actually rupture and leading here to the extradural hemorrhage, that we will discuss later. But you see, this is the area. So, this area which you are actually facing is something that is actually forming the lateral side of your temple, and when your temporal fascia is now coming after its attachment with the zygomatic arch, when it comes over, so you know that it will cover it now, it will cover, it will not be fused with the bone, because zygomatic arch is little raised here. So, it will actually coming here and coming in such a way that the gap will be created. So, that means if for example you are pressurizing your temporal fascia, you see it will not be touching the bone, there will be a small gap here. And that gap which will be actually present here, because this temporal fascia until what spot actually when the temporal fascia is there, this will be when you are reaching up to the superior temporal line, because on the lateral side you have got 2 very important landmarks. One is called the inferior temporal line, another is called the superior temporal line. So, the fascia which I was telling you, this called the temporal fascia, after it is in fact is attached to the zygomatic arch, continues its journey over the lateral side to the pterion bones, but not attaching with them. So, it is also, you know that when it reaches the superior temporal line, it will get fused with the superior temporal line. It will get fused with the superior temporal line. So, between this temporal fascia and the underlying bones of the pterion, or the bones which constitute the pterion, there is a gap, and that gap is called temporal fossa. So, if you put your hand here, you see that if you remove this temporal fascia, or you can say put your hand here, or you are just retain that temporal fascia, and if you are putting your hand under the zygomatic arch, your fingers will be passing actually and will be touching the, you see the palmar surface of your fingers will be touching these 4 bones, means in the pterion area, and you are going more upward here, you will stop at the fusion of this temporal fascia with the superior temporal line, means your superior limit of this fossa has finished. And where your fingers are actually, here there is a very prominent and important muscle of mastication, that is the temporalis muscle. So, almost entire, you see almost 99% of your area of your temporal fossa is occupied by the temporalis muscle, which takes origin from obviously the bones which are forming the pterion, but this time not up to the level of superior temporal line, but up to the level of inferior temporal line. means they are actually taking origin from the all these bones here below the inferior temporal line, and also from the fibers are taking origin from the overlying fascia, and overlying fascia means the temporal fascia. Yeah. And when all these fibers will unite together, they will form a tendon, and the tendon will pass deeper to, because your fingers are passing deeper to the zygomatic arch, so the tendon is also passing deeper to the zygomatic arch, and it is passing deeper to zygomatic arch to catch hold of and will make its insertion over the inner aspect of the coronal process of the coronal process of the mandible here. So it will contract, so it will pull the mandible up here. So it is pulling the mandible up, and it will be called as like the muscle of mastication here. And then this is what we call here the temporalis muscle. So the main content of this temporal fossa is the temporalis muscle. There are some other contents also which will come and we will see them in the neurovascular bundles, but this is actually the temporal fossa here. Now if for example your hand is here in the temporal fossa, its floor is being formed here by all the bones which you have seen already. See the bones which are forming the pterion, like the sphenoid bone and the parietal bone above and sphenoid bone below, and they are having a joint with each other. It's called the suture, this is called sphenoparietal suture. This parietal and sphenoid pair is anteriorly having a suture with the frontal and posteriorly having a suture with the squamous. So you see H-shaped suture has been created here over the pterion. This is the floor, because your hand here and you are feeling it now. And if you are feeling it, this is the hard floor and the bony floor, and if you are actually lifting your fingers here and feeling the roof will be the same temporal fascia. This is the roof. And if you are actually continue your journey upward here, your fingertips will stop at the superior temporal line. This is your superior boundary. And even on the posterior side also the superior temporal line continues. So posterior boundary is also the superior temporal line. This is the line of fusion between the temporal fascia and the superior temporal line. This is the fusion point here, the fusion line here. And above also same. But anteriorly you will see, when anteriorly you are feeling here, your this frontal bone will come, and to some extent zygomatic bone also. So you see, if you are actually feeling here anteriorly, you will feel the zygomatic bone and the frontal bone. Anterior boundary is formed here by this here. This is called here. You can say the temporal process of the the frontal bone and the temporal process of the zygomatic bone. So you can feel them here anteriorly. This is your anterior boundary. Superior boundary, superior temporal line. Posterior boundary, again superior temporal line, where the temporal fascia fuses with the superior temporal line. Floor is formed by the pterion bones, and roof is formed by the fascia, that is called the temporal fascia. Inferiorly it continues in a gap, you can say. Inferiorly you can say your fingers will go down and will be passing deep to the, in a gap deep to the zygomatic arch, where your tendon of the temporalis is also going. So your fingers will actually go there, and where you will feel the roughness, and here the greater wing of the sphenoid, you know that, because here your fingers are touching continuously down here over the outer surface of this sphenoid bone. This is called the greater wing of the sphenoid. So suddenly you will see that the greater wing of the sphenoid will stop. It stops here, means its vertical course stops, and it will have a horizontal course, means it bends here. Bands here, a crest will be created. That is called infratemporal crest. And the infratemporal crest, you know that deeper to the zygomatic arch, infratemporal crest, because deeper to the zygomatic arch will be little away, and there is a gap here. So this will be the temporal fossa, and we told you already. So that means if your hand is in the, or your fingers are traveling, you know that is under the zygomatic arch. So if you are coming from above downward here, and above downward means deep to the zygomatic arch, and you are traveling, your fingers are touching the greater wing of the sphenoid obviously, and suddenly you see that the vertical journey of the temporal surface of the greater wing of the sphenoid will suddenly stop, and it will have a bend now to become continuous with the horizontal part of the greater wing of the sphenoid. This is called the infratemporal surface of greater wing of the sphenoid. Right at the junction between the temporal surface and infratemporal surface, there is a crest. This is called the infratemporal crest. And infratemporal crest will tell you that the temporal fossa is over and infratemporal fossa has started. This will actually form its inferior limit, you can say. So the inferior limit is the infratemporal crest, deeper to the zygomatic arch. And superiorly it is a superior temporal line, posterior also superior temporal line, and you can say anteriorly the zygomatic bone and the frontal bone, and floor is formed here by the bones of the pterion, and the roof is formed here by the temporal fascia here. This is called the temporal fossa, whose major content, you know, that is almost lone content is the temporalis muscle here. Obviously there are vessels and nerves also, those nerves which are supplying the temporalis, and also some vessels which are superficially present there also. This is something temporal fossa here. So by now you have seen the various views of the skull from outside. You have done here the cranial cavity, you have done the other fossa like the pterygopalatine fossa and infratemporal fossa, and now the fossa that is called the temporal fossa. You will see some more like the cavities, like one is called the orbit, the bony orbit, the nasal cavity, the oral cavity. Nasal cavity and oral cavity we will do in the nose and the mouth, but others like the bone of the orbit, you see that is called the bony orbit. This you will do during these osteology sessions here. In this session we are going to discuss here one of the most important topics, especially related to the skull and its cavities. It's called the infratemporal fossa. Now infratemporal fossa, as the name suggests, this is a space, or you can say cavity, or you say a kind of a some accommodation at the base of the skull. At the base of the skull, how it is bounded from all sides by different bones, this is actually our today's discussion. This is called the infratemporal fossa, means we have another fossa also, that is called the temporal fossa. Temporal fossa means it is here over the temple, where you can feel this here. Under the skin and under the deep fascia, under the temporal fascia, what you feel here, this is called temporal fossa. This is almost all occupied by, almost entirely occupied by a muscle, one of the muscles of mastication, that is called the temporalis muscle. And in that muscle you see that it's almost all occupying this region, which we will discuss later, that is called the temporal fossa. But once you will actually go and will travel through the temporal fossa, there will come a spot here, or there will come here a milestone, that is called the infratemporal crest, that we will show you here in the skull also. This is called the infratemporal crest, and when you reach the infratemporal crest, means if your hand here, you see, if your finger is in the temporal fossa and you want to access the infratemporal fossa, your finger will pass down through the temporal fossa deeper to the zygomatic arch. Zygomatic arch you can feel here also, not superficial to that, but deeper to the zygomatic arch. You will see by the side of the temple and outside being the zygomatic arch, there is a big hole, you can say, there is a big space, and when you pass your finger through the space, you will feel that at one spot there will come a very important milestone or a landmark, that is called the infratemporal crest. And once you will reach the infratemporal crest here, you see immediately that bone that will be incidentally at that area is the sphenoid bone, that will bend now, it will bend. And when it will bend, here crest will be created. And when the crest will be created, so you can say you have a temporal surface of the sphenoid bone and you have got the infratemporal surface of the sphenoid bone, and both of these surfaces will be separated, or you can say demarcated by here a crest, that is called infratemporal crest. You see, so that means when you will actually pass your hand under the base of the skull here, means the same bone has bent here to form the infratemporal surface of the sphenoid bone, and incidentally there is the greater wing of the sphenoid bone that has gone on the under surface of the skull to form the base of the skull, or you can say form the inferior surface of the skull. So it has gone down there, and you have entered into a fossa, that is called the infratemporal fossa. You have to actually watch here infratemporal fossa. We will clarify these things on skull also, but you watch here theoretically what the infratemporal fossa itself is and what bones they are bounding them from all sides here. All sides means just like a room you are. You have a roof which is forming the base of the skull. You have anterior wall is formed by some bones. You have the posterior wall, is formed by again some bones. And on the two sides you see that once you have entered into the infratemporal fossa, on two sides you have got the medial wall and you have got the lateral wall. You do not have the inferior wall because it is not actually a 6-sided closed cavity, it has the 5 walls. It has the roof, anterior wall, posterior wall, lateral and medial, but it is not having the floor because floor is becoming continuous here with the neck here. So, you are in fact going from the roof until you come down here. You see, watch the anterior wall first. See, if you are looking at and you are inside the infratemporal fossa and you are looking at the anterior wall, you will be looking like this. You will see this is here. So, this will be your anterior wall, this way. This is the anterior wall. Now, you are basically in this region. I told you that already that if this is now a sphenoid bone on the side here, on the temporal fossa, if this is a sphenoid bone, above is the parietal, okay, first of all you see this also. This is called the sphenoid bone. And what is this? This is sphenoid, but this is called greater wing of the sphenoid. This is greater wing of sphenoid. This is greater wing of sphenoid, which you can feel here. And if you have seen previously in the area at the lateral side of your skull, and the normal lateralis here, and the outer surface, you see that outer structures or the outer bony surface landmarks here. On the lateral side, there are 4 bones which unite here. And out of these 4 bones, the down one here is the greater wing of sphenoid. Above this greater wing of sphenoid is making a suture with this bone that is called the parietal bone. That is why the suture has been actually formed here. This you can feel here. And if the suture is formed here, that is called the sphenoparietal suture. It is between the parietal bone above and the greater wing of the sphenoid below. But you see that these 2 bones, they are forming here a continuity. But on the back side, both of them, they are, you say, they are making here a joint, again a suture with another bone. This is called a temporal bone. And this bone is the temporal bone, scale-like, it's a fish scale-like bone, you see that. This is called a squamous temporal bone, squamous part of a temporal bone. This is called the squamous temporal bone. And that's why the suture has been created, is called the squamous suture. Now, in that area, you see in the temporal zone area, you see that in the temporal fossa area, we have got posteriorly very large squamous part of the temporal bone. Anteriorly, we have got a pair of bones which join together. Above parietal, below sphenoid. And if you have seen here, similarly when the parietal and the sphenoid combination, posteriorly it is making suture with the squamous temporal bone, anteriorly they are making suture with the frontal bone. This is the frontal bone. Now, if these all areas you can feel here, here is the frontal, here is the parietal, in between in this area above is the behind will be the temporal, here is the frontal, but in the middle these are 2 bones. So, that means in this area H-shaped suture has been created here. You see this H-shaped suture. Above parietal, below temporal. This is one vertical limb of the H. On other side is another vertical limb of H. Above you see parietal, below is the frontal. And both these vertical limbs of the H, they are united with each other by means of the horizontal limb of the H. And this horizontal limb of the H is formed here by, in reality it has been formed here by the sphenoparietal suture. And in this area, when this is formed here, an H-shaped suture is formed, means 4 bones are joined together in that area. And all the bones which are coming here closer to with each other and forming the sutures, they get here thinner now, little weaker. So here sphenoid bones greater wing is weak, here parietal bones is also weak, here squamous bone already weaker, and here also the frontal bone is weak. So that the spot which in fact has been created here, where the 4 bones are joining with each other in H-shaped manner with the 3 sutures now, 1 horizontal and 2 vertical. This area is called pterion. Many questions come on the pterion, because pterion is the weaker area. You see the weakest area here on the lateral side here. But all these structures, they do not belong to the infratemporal fossa. They belong to the temporal fossa, and they are belonging to the temporal fossa. If you are in the temporal fossa, so that means when your hand is passing along this, and hand is passing now along the sphenoid greater wing here, you are coming down here, you will see that you will reach in this area. Reaching in this area, you say a crest will come, and this crest will come in such a way that you see that when here is there, this temporal greater wing of the sphenoid bone is coming here and here. This is the temporal side of the greater wing of the sphenoid. Immediately the greater wing of the sphenoid will make a 90-degree angle this way, like this. You can say this way. So you have now not just the greater wing of the sphenoid's temporal surface forming the part of the temporal fossa. Right at this spot where there is a crest here, it will form now the undersurface. Infratemporal aspect of the greater wing of the sphenoid, means on the base of the skull it has come. So that means on the base of the skull has come, now you have entered into the infratemporal fossa. Means most anterior part of the infratemporal fossa is formed by the infratemporal surface of greater wing of the sphenoid. So that means your infratemporal fossa has started from where? From infratemporal crest. Before that, it was the temporal surface of greater wing of the sphenoid that you are watching here. Below that, forming the base of the skull, this is infratemporal surface of the the greater wing of the sphenoid. And in the infratemporal surface of the greater wing of the sphenoid, you will see two foramina. So that means if you have entered into the infratemporal surface of you have entered into the infratemporal fossa, means you are passing your hand under the infratemporal surface of the greater wing of the sphenoid, means you are actually studying the roof of the infratemporal fossa. And this will be most anterior part of the roof of infratemporal fossa. If for example the greater wing of sphenoid is doing this, why not the ischiumous portion of the temporal bone will also do the same thing? Because the ischiumous portion of the temporal bone which is forming here, most of the part of the temporal fossa, when it will reach here, you see, when it will reach here, that will also bend here, and bend here means it is forming here the undersurface, I say inferior surface of the skull. And inferior surface of the skull means next half of the roof of infratemporal fossa will be formed by the ischiumous part of temporal bone. Means both of these bones, not the frontal, I say, not the parietal can't come down, but you see this is sphenoid and ischiumous. These two portions which were forming now, you see that, which were forming the temporal fossa's boundaries as temporal fossa's floor, they are bending down here. They are bending down means anteriorly greater wing of sphenoid is forming the roof of the infratemporal fossa, and ischiumous portion of the temporal bone, it is forming the posterior half of the roof of infratemporal fossa. Means the roof is formed by two bones, anteriorly the greater wing of the sphenoid's infratemporal surface, and posteriorly the ischiumous portion of the temporal bone's infratemporal surface. And here they are the temporal surfaces, and temporal surfaces forming the temporal fossa's boundaries, and they are forming infratemporal fossa's boundaries. And when you are looking at the roof now, so roof is formed by these two things here, and roof has formed by these two things. And when you are actually forming here the roof, for example, in the roof, so you will not just actually be looking at their boundaries, you have to watch here what passages now they are present in the boundaries. They are passages means if you are looking at the roof, for example, anterior half of the roof is formed by the greater wing of the sphenoid's infratemporal surface, and posterior half of the roof is formed here by the ischiumous portion of the temporal bone's infratemporal surface. But when you are actually looking at the anterior half of the roof, in the anterior half of the roof there are two foramina. Means this time you will not just say the bones forming the roof of the infratemporal fossa, but you will see some passages into the infratemporal fossa. Means if you are looking at the roof, in the two foramina you will actually find in the greater wing of the sphenoid. You will see these foramina. Now I am actually making here two foramina here, that we will show you in other illustrations also, but you watch here, in this area you will see here two foramina. One foramen is this is oval like. This I am giving you passages in the infratemporal surfaces, passages in the roof of the infratemporal fossa. Bones, which bones they have formed, I have already told you, but these are actually forming here. Number one, this is the foramen. You see the margins of this foramen is oval like, that's why this is called the foramen ovale. Simply this is also called, sometimes you see that more famous like pronunciation is the foramen ovale also. So this is called the foramen ovale. So you can see this foramen is called the foramen ovale. This I am giving you idea about the passages in the roof of the infratemporal fossa. Foramen ovale. This is number 1 foramen. The first passage from the infratemporal fossa. This is from the roof, anterior part of the roof, in the greater wing of the sphenoid's infratemporal surface. And this is the foramen. And we have already told you many times that whenever the word foramen comes now, or you will just pronunciate the word foramen, you should know 4 things about any foramen. Foramen, or a fissure, or a canal, or a meatus, or anything which is actually present in the cranial cavity, or any other part of the skull. If it comes, you see that you will just go for 4 answers about that. Number 1, name of that foramen. You already know that is called the foramen ovale. Number 2, location. Location is theoretically you should know that where it is located. Where it is located means, if for example skull is not on the table, you want to actually locate this foramen, and you are in fact guiding some person that this foramen is present there. Means phone, you are actually telling him on the phone, you don't have a skull, but he has the skull in his hand. And now you are actually telling him that where this foramen is located. You will say that this foramen is located in the infratemporal fossa, in the anterior part of, in the anterior part of the roof, in the greater wing of the sphenoid. It is the location. So it is lying in the greater wing of the sphenoid. Okay. This foramen is there. This is the second. This is the second answer about any foramen, any fissure. Third will be what 2 regions of the skull it communicates. And you will see that in one communication means in one fossa you yourself are standing, means in the infratemporal fossa. So you should have actually a wire in your hand always when you are actually doing the skull. Wire means you should have a steel wire here, and you put this wire in that foramen. So it will communicate, means you see the other end of this wire, it comes to or where it appears. One side already you know that because you are actually putting here in from infratemporal side here. And where the other end of this wire has actually gone here. You will look at this, it will go into the cranial cavity. And if it is going into the cranial cavity, so foramen ovale will guide you into the cranial cavity. Which part of cranial cavity? In the middle cranial fossa. Means the third answer will be it communicates between infratemporal fossa and middle cranial fossa. Means any structure can leave the infratemporal fossa, can go to the middle cranial fossa, or it can come from middle cranial fossa into the infratemporal fossa. This is the third answer. Fourth answer will be, if it is being done like this, what structures are transmitted through that? At this stage, we will not actually count the structures, which structures are passing through that. This will be done only when we will actually discussing the neurovascular bundles. At this area, this fourth answer we will not actually give. Fourth answer, it will be applied, it will be only used when we will be doing the neurovascular bundles here. Here, up to here, 3 questions, answers you will actually will give in any fissure, any canal, any foramen, any meatus like here. Number 1, name. Number 2, location. And number 3, which 2 or 3 compartments, or which 2 compartments at least it will communicate. This communicates between cranial cavity, middle cranial fossa and the infratemporal fossa. This is the first passage which you have seen. Very close to that. We will see that very close to that. If this is sphenoid bones under surface, I say sphenoid bones, greater wing of the sphenoid bones, infratemporal surface, you will see that and you will feel that there will be from the infratemporal surface of the greater wing of the sphenoid, one small spine projects. That's a very sharp spine. You can actually feel with your thumb, you can feel just like a pin, it will prick you. That spine simply is called the spine of sphenoid, embryologically very important. This is called the spine of sphenoid. In the base of the spine of the sphenoid, another foramen just posterior lateral to this ovale foramen you will actually see. Very small foramen, because it is lying in the base of spine of the sphenoid. That's why this foramen's name has become foramen spinosum. This is second passage which I am actually showing you in the roof of infratemporal fossa. This is called the foramen spinosum. This is second passage we have actually discussed here. Incidentally, this is also in the roof. And when this second passage means the second foramen comes, again 4 questions. Number 1, name, foramen spinosum. Number 2, location. In the roof of the infratemporal fossa, in the base of the foramen is called in the base of the spine of the sphenoid. Number 3, if you put your small wire through that, you see it will go from infratemporal fossa again into the middle cranial fossa. So that means communicates the infratemporal fossa with the middle cranial fossa. And number 4, what structure is transmitted through that? That you will do in the neurovascular bundles. Number 3. This is the second passage. When you go little behind now, still posteriorly, again in the roof again in the roof, will go posteriorly, you will see that here it will be formed, the posterior half of your infratemporal fossa's roof is formed by squamous portion. And it is this squamous portion and it has gone below also. Means temporal bone has many structures. You see temporal bone has many parts. The one which is you actually seeing here is called the squamous part. And will come here on the back side, on the back of your auricle, you will feel here a process. That process is called the mastoid process. This is the mastoid process. And this is the mastoid process. Between mastoid and mastoid process, just in front of mastoid process, little more deeper here, little more medially here, there is another process here. This is called styloid process. These all are the parts of a temporal bone. It's called styloid process. And incidentally, where the styloid process starts and mastoid process also here, in the base of skull, you will see here a foramen also. This incidentally I am actually telling you has nothing to do with your infratemporal fossa. Here this is very important foramen. This foramen, because it's lying between the styloid process anteriorly and the mastoid process posteriorly, both being the parts of the temporal bone. So that's why this foramen is named as the stylomastoid foramen. Very important because this is the foramen from where exits your 7th cranial nerve, that is the facial nerve. And if you will actually pass something through this styloid, through the stylomastoid foramen, a pin, let's say the pin here, if you are actually putting here, the pin will go for a few centimeters inside. Inside means there is a canal. This canal's name is the facial canal, because facial nerve comes out after traveling through the facial canal. And this facial canal is lying here in front of the mastoid process. Means through the stylomastoid foramen you are actually watching here. This will come when sometimes we will actually be discussing the facial nerve. But you see, this is now the roof. I have told you that under the roof, means in the roof you see that. In the roof is not just the squamous part of temporal bone, but we have some other parts of the temporal bone that you will also see on the undersurface of the skull, which is also forming, to some extent you see that will forming the roof of your, infratemporal fossa. Again temporal bone, and that temporal bone's name is the petrous part of the temporal bone. Though it is not visible here on the lateral side here, that will be also visible here, where? On the undersurface. This is not forming as such the boundaries are the forming the roof of your infratemporal fossa, but this is present there. This is called petrous part of temporal bone. Not just the petrous part of temporal bone, because here is another bone also, again temporal bones. Temporal bone has a lot of portions here. One portion you see, this is called the squamous part. Then you see on the back of your auricles you are feeling here this process called mastoid process. Under surface of the base of the skull, spine like structure, long structure is coming down here, is called the styloid process of the temporal bone. Then we have got after the auricle you see that, before you see that, after the auricle it is continuous with the bony canal, that is called the external acoustic meatus. This is also present. This is external acoustic meatus. This one is the external acoustic meatus. This is the passage through which the sound waves are actually going here and striking the eardrum, that is called the tympanic membrane. So this is now something you are watching. So we have got this. And at the same time, on the undersurface of the skull, we have another part of temporal bone also, that is called the tympanic plate of the temporal bone. So we have a tympanic plate, we have petrous part of temporal bone, we have the undersurface of the squamous part of temporal bone, mastoid process, we have the styloid. All these parts you can actually feel on the undersurface of the skull, and some parts you can see on the lateral side also. Now between the tympanic plate of the temporal bone and the petrous part of a temporal bone, both you can see on the undersurface of the skull. There is a fissure also. That fissure we will show you on the skull. This is called the between petrous part of temporal bone and tympanic plate of temporal bone. Incidentally, these two bones you can see here on the undersurface, I say on the base of the skull, and they are also forming the boundaries of some part of the roof of your infratemporal fossa. So between these two parts of the same bone means temporal bone, petrous part of temporal bone and tympanic plate of temporal bone, there is a fissure. because it is between the petrous part and the tympanic plate of the temporal bones. That is why that fissure is called petrotympanic fissure. Very important fissure. This is called petrotympanic. Means again here I am actually giving you symbolically just a fissure here in the roof. You call this fissure as the petrotympanic fissure. Petrotympanic fissure. This is the third passage. You say, what passage? This is a fissure. Okay, this is fissure. But when this fissure is there, or a foramen, or anything, or a canal, or a meatus, or this, you will ask yourself 4 questions. Number 1, name. You see petrotympanic fissure. Number 2, location in the base of the, in the base of the skull, or you can say in the roof of the infratemporal fossa. In between two bones, a very small fissure. It's not a big fissure as such. You cannot actually see this fissure. You should just see just a groove you see. So you see this is called the petrotympanic fissure. Between the petrous part of temporal bone and the tympanic plate of the temporal bone, there is a fissure in the roof, in the most posterior part of the roof of your infratemporal fossa. Number 2, this is location. Third one, if you pass something through that, it's not very easy to actually pass something through that. This is very fused here, so it's just a groove here. But if you try to pass something through that, it will guide you into the middle ear. If you guide you into the middle ear, and middle ear's other name is the tympanic cavity. So it is actually guiding you into the middle ear. So that means from infratemporal fossa, anything can go to the middle ear, or from middle ear, anything can come here into the infratemporal fossa. So this is a passage again between the middle ear or a tympanic cavity to the infratemporal fossa. Very important nerve, one of the most important nerves in your head and neck. In fact, will emerge from this petrotympanic fissure that has passed through the entire length of your middle ear cavity. Now it has entered into the infratemporal fossa, and that is very important nerve. That is called the cauda tympani nerve, one of the most important nerve. You see the 4 major nerves which you will actually see. These are the branches of the various nerves of the cranial nerves. They are very, very important. That we will actually tell you in the neurovascular bundles. But this cauda tympani nerve, that will actually come. But we will not discuss here what is coming out of it. 3 questions here, not the 4th one. What is transmitted? This is not our business today. But we want to actually answer 3 things now. 3 things means number 1, the name. Number 2, location. Number 3, what 2 compartments are, say 2 cavities it communicates. Infratemporal fossa with the middle ear. So something can go from infratemporal fossa to middle ear, or something can come from middle ear into the infratemporal fossa. This is 2-way traffic. Same in the oval, same in the spinosa. These are the 3 communication, 3 passages in the roof you have actually seen here. Now after the roof, you see the floor, and floor we don't have any floor at all, because this is continuous with the spaces of the of the neck here. Then you will actually look anteriorly. You are in the room now, you are seeing and looking anteriorly. And if you are here, you look anterior here. Because we are in this fossa, and we have actually gone into the fossa. And if you have gone into the fossa, for example, okay, if this is here, you feel here mandible. You are feeling the mandible here. This is called the body of mandible. And there is an angle, and this is the ramus which is standing here vertical. This is the ramus of mandible. And when this ramus of the mandible is present here, means when you will remove the ramus of mandible, you will enter into the infratemporal fossa. Actually, the ramus of the mandible has been removed from here to show you the inside story of your infratemporal fossa. Here, the mandible has been removed because this is now the fossa. This is called the mandibular fossa, where the head of your mandible fixes here to form the temporomandibular joint. And we told you that then there will be the ramus of mandible. This is ramus of mandible, and all these things are there. So this was the ramus which we have removed. We have removed the ramus to show you the inside story here, because infratemporal fossa is a 5-walled structure. The floor is not present. 5-walled. Out of these 5 walls, 1 wall you have removed totally, so that you can enter into. So that means when you have entered into, and now you are looking laterally, this will be your lateral wall. What you have removed? The ramus. Means lateral wall is of infratemporal fossa is formed by the ramus. And in the ramus, you have seen here. So that means from inside, if you are looking at this, you will see the ramus of the mandible. And in the ramus of the mandible, you have got a lot of things here. Above, you have got here on the back side, you have the head of the mandible. In front, you have got the coronoid process of mandible. Means posteriorly, the head's other name is the condyloid process. Then anteriorly, you have got the coronoid process. Between a coronoid process and the condyloid process, there is a notch, that is called the mandibular notch. And then ramus is there. And if you will look at the ramus If you are in infratemporal fossa, lateral boundary, if you look at your ramus here, in the ramus there is a foramen, and that foramen's name is the mandibular foramen, very important foramen. And it's the mandibular foramen. You look at the mandibular foramen, if you pass the wire through the mandibular foramen, this wire will go actually 2 to 3 inches into the body of the mandible. So if you are actually looking at, so if you have removed the mandible, ramus of the mandible, and you have entered here, just like you open the door and now you are entering into the room. And we are entering into the room and now close the door. After closing the door and entering into the infratemporal fossa, if you look at the roof, already you have discussed what the roof is being formed. Anteriorly by the, anteriorly by the under surface of, infratemporal surface of the greater wing of the sphenoid, and posteriorly by the infratemporal surface of the squamous part of the temporal bone. And in that you have seen 3 passages also, ovale, spinosum, prototympanic fissure. And after that, when you look at this closed door which you have actually closed, this is the ramus of mandible. A ramus of mandible, and you see the ramus of mandible, it is almost quadrangular, and above you see this ramus of the mandible is splitting up into the 2 processes. One is this is called the condylate process of the head that fixes here with the mandibular fossa to form TMJ, that is called the temporomandibular joint, and anteriorly it has got the spiny structure, that is called the coronary process, and between both of them there is a curved notch here, and curved notch, that is actually called, this is called the mandibular notch. So that means if you are looking on the lateral side, your lateral boundary is formed by these landmarks, and all these landmarks belong to the ramus of the mandible. And if you are actually looking at the ramus, and if you feel the ramus here, outside ramus is pretty smooth, you see, but inside the ramus is not that smooth. In the ramus we have got a foramen. That foramen's name is the mandibular foramen, very important foramen. And that mandibular foramen, if you pass the needle, or you say pass some wire through the mandibular foramen, it will pass through that almost 2 to 3 inches, it can pass through that, and that passing through that means into a canal, and that canal is present where? That canal is present in the body of the mandible, because mandible has 2 parts. You will do the mandible later, but you see this mandible has 2 parts, one is the body, another the ramus at an angle. So that means if you pass something through the mandibular foramen, this wire will pass through the mandibular canal, through the body here, and incidentally it will come out of this foramen here, means here in the chin you see that, under the skin here in the bone you will see this foramen, it is called the mental foramen, means other side of the wire will come here through the mental foramen, means you are putting something through the mandibular foramen in the infratemporal fossa which is lying in the lateral wall, but that wire will actually, the other side or the end of the wire will come out of the mental foramen. A very important canal you have travelled, and this canal is actually travelled here by the nerves and the arteries here, a very important artery, very important nerve especially, and that nerve one by one will give branches to the roots of your lower teeth here through these alveolar processes. That is why this nerve is called alveolar nerve. Previous name dental nerve, but today you call them alveolar nerve, because these are lower teeth, that is why this nerve's name is the inferior alveolar nerve, a very important nerve is. But we will not actually discuss what inferior alveolar nerve is doing in the mandibular canal, but we know that from infratemporal fossa, one thing, this is the 4th communication, or the 4th communication that is present in the infratemporal fossa is the mandibular foramen through the mandibular canal, and you coming out of into the into your mental foramen here. That means the 4th communication in the lateral wall, this time incidentally, which we can't show you here because we have removed this. So 4th communication you can write here in the lateral wall, this is the mandibular foramen. This is mandibular foramen, 4th communication, and that 4th communication is the mandibular foramen lying in the ramus of the mandible, and it communicates the infratemporal fossa with the face, a lower part of the face you can say, or chin you can say. And what is passing through that? This is our 4th question that you will do in the neurovascular bundles. This is one way. Another way will be that if you are looking on the lateral side, I told you that behind is the condylate process which is forming the TMJ, and anterior is the coronary process. In between there is a notch, that is called the mandibular notch. So that means if you are looking laterally, you can see the mandibular notch. Not necessarily you can pass through any foramen or fissure. Why don't you actually pass through the mandibular notch also? Means some neurovascular bundles will pass through the mandibular notch, and immediately when somebody will come out of the mandibular notch, it will appear on the face. Means 5th communication, this time on the lateral side, the passage in the lateral wall, it is the mandibular notch, and mandibular notch name, its location, and its communication between 2 compartments, and 4th will be the contents. So this is the 3rd, this is our 5th communication, is this, is called the mandibular notch. Then in the lateral wall there is sixth also. You say where is sixth? Actually sixth is not present, but because you can pass, if you can go to some structures or some parts of your face here and there, you pass through the mandibular foramen, through the canal to the mental foramen, number one. Another through the mandibular notch, I say you come here into this buccal region. Then you don't use any notch or any foramen, but this time because there is a head which has already formed the TMJ, below the head there is a neck. And if you want to come out of your infratemporal fossa, come out of the infratemporal fossa, if this is now your head and this is neck, so behind the neck you can come also. Means this is your head and behind is your neck. So means if any structure is coming out of, you say out of the infratemporal fossa laterally, behind the neck it can wind round and pass in front of your auricle, can go to the temple. Means and from the temple it can come onto the scalp. Means third thing will be around the notch, I say around the neck of, though there is no foramen as such, but this is one other way to come out of the infratemporal fossa, from infratemporal fossa to the temple and scalp. And when you are passing into the temple and scalp, why not you actually talk a little bit to the auricle also. A very important nerve will actually be passing through that we will do later. So sixth will be winding around the neck of mandible. So this is 4 communications again on the lateral side. This will give you idea that your infratemporal fossa actually is talking to more than 9 or 10 regions. And this will give you idea it is a very important zone from where the neurovascular bundles in fact will be sent like you see envoys to all the things, all the regions here. They are spread here. And you will actually see how this happens. You see 6 communications by now, 3 in the roof, 3 in the lateral wall. Now if you are looking at 3 in the lateral wall, 3 in the roof, see now on the back and the front. So see on the back now, posterior side, easier, see posterior side. If you are inside and if you look posterior, this is the posterior wall, and posterior wall is nothing but this one. This is called styloid process. This is the posterior wall. No communication, nothing at all, simple. Posterior wall is formed by, means if your hand is here in the infratemporal fossa, and if you see your hand in the infratemporal fossa and you can feel behind here, you will feel here very long styloid process, and you will see that this is the posterior boundary. Posterior boundary you have seen, roof you have seen, floor is no more, laterally you have seen. Now see in the front now, just in front of styloid process. You see styloid process here, and you are seeing here now just anterior. And if you anterior you see, you are watching this hole you see from here till here, and the back side also is a maxilla. A very important bone, you see this is called the maxilla. And if you are here in this region, so that means if your posterior wall is in here formed by the styloid process, anterior wall will be formed here by the back surface or the posterior surface of the maxilla. And if the posterior surface of the maxilla you are watching in this area, posterior surface of this is maxilla now. This is called the maxilla, posterior surface of the maxilla. This is the posterior surface of maxilla. And here you are watching the styloid process. So behind styloid process, anteriorly posterior surface of maxilla. And in the posterior surface of the maxilla, in the infratemporal fossa, the anterior boundary. So here see some foramina. And this maxilla which you are actually watching is not a solid bone. Inside the maxilla you have got hole, it is kind of a hollow. Inside it is having here airy sinus, you can say. Means it is not like a stone, it is totally hollow inside. And if you want to knock it like this, it will have a resonance. Why? Because inside it has the air, and that air inside this maxilla, it is called the sinus. We call it the maxillary sinus. A single big sinus is there, that's why we call them antrum, basically maxillary antrum. It's not having a spongy compartments. It is totally single sinus, big room, you can say. It is roomy inside, and the air will come from nose into that sinus, it communicates. But here on the back side you are watching here. So that means if you want to approach this sinus, any wall of your maxilla, you can put some needle and form the foramen, and you can approach inside the maxillary sinus. And if you will be going into the maxillary sinus, into the room, for example, in the sinus you are going from any wall, for example, at this time you are going from posterior wall, because you are in fact visiting your infratemporal fossa. And if you are going into the sinus, so you jump into the sinus, in the maxillary sinus. we jump into the maxillary sinus. Now you walk inside the sinus you are walking, and inside the sinus if you are walking means inside your maxillary sinus you are walking on the floor, and if you are walking on the floor of your maxillary sinus means here this incidentally it is the roof of the oral cavity, means if you are here and you are feeling the sinus you say sinus floor, and that floor is in fact is the roof of your oral cavity, and that floor of the maxillary sinus or roof of your oral cavity there are teeth. These are the maxillary teeth, you see. So that means that these two foramina are important to in fact to give nutrition through the blood vessels to these teeth, or they are giving sensation to these teeth via the nerves. That's why these foramina have been actually given to the posterior surface of the maxilla to make holes so that the neurovascular bundles can enter through them. These are the dental nerves or the dental arteries. Old name dental arteries, but their new name is alveolar arteries. That's why these foramina, they are called alveolar foramina. Means if you are actually looking anteriorly, it is formed here by the posterior surface of maxilla boundary, and in the boundary you have a communication. Seventh communication, that will be the alveolar foramina. This time in the anterior wall, and I have already told you 3 in the roof, and I have already told you 3 in the lateral wall, and this time I am actually showing you this one, the 7th one. This is inside I say in the anterior wall. I say anterior wall, these are called the alveolar foramina. This is our 7th. There are 1 or 2, maybe 1, maybe 2. It's called the alveolar foramen, or you can say alveolar foramina. See, this is 7th communication in the anterior wall. Name, location, and you say 2 communications from where to where. And now you see the name alveolar foramina, location, and the posterior surface of the maxilla, which is forming the anterior boundary of the temporal fossa. And communication, pass the wire through that, and you see there's a wire on the other side has gone into the maxillary sinus. And if you are going into the maxillary sinus, you can easily approach the roots of the teeth. Which teeth? The maxillary teeth. So these will be the superior teeth, I say maxillary teeth. That's why these nerves are called superior alveolar nerves. See, if for example you are watching in this area, so you are actually watching this alveolar foramina. So we have the alveolar foramina. So inside the room you are, roof you have already watched, anterior wall you have already seen, posterior is just a spine, this is styloid process. Lateral you have seen already the ramus of the mandible. Floor you don't have at all. What is now remaining? If the floor you don't have, roof you have seen. Lateral wall you have seen, the medial has not been seen yet. Anterior wall you have seen, and the posterior wall also. Now you are actually seeing not just this, but when you have seen the anterior wall, if you are in the room, see the entire wall now anteriorly. Okay, 2 foramina, they have gone into the sinus. But when this anterior wall, you see, for example, if this is the anterior wall, like here, this is maxilla, and when maxilla's anterior wall finishes here, immediately starts the roof now, roof here. Understand? If the roof is this, now if the roof is this, so if this is now maxilla, posterior surface, and this is the roof, and roof which portion? Anterior half of the roof obviously, because posterior half of the roof is still there until posteriorly who stops you? Styloid process stops you. Styloid process will stop you. But you see anterior half of the roof. Anterior half of the roof you already know is being formed here by the greater wing of sphenoid bones bending here at 90-degree angle. So that will become infratemporal surface. Means if this is now anteriorly your maxilla, when maxilla finishes as an anterior wall and immediately roof starts, so what starts? Greater wing of sphenoid starts, and greater wing of sphenoid bone, but the anterior wall is formed by maxilla and roof is formed by greater wing of sphenoid. And greater wing of sphenoid and maxilla, they mostly remain separated. So if I am actually showing you here, they are not in fact just like your room where your anterior wall finishes and immediately roof starts at 90-degree angle, they are separate. Means you can see if I am actually showing you here your maxilla and you are watching here this greater wing of sphenoid, they are separate. If they are separate, gap is there. Gap where? Again in the anterior wall. In the middle or right at the top, just at the junction between the anterior wall and the roof, in an angle where the 90-degree angle is there. The angle is actually not formed here, there is a gap. A gap will be small or very large gap will be there, very large gap, and this time you don't call it a foramen, you will call it a fissure. So again in the fissure, where you will see this fissure is, you will just count it in the anterior wall, just at the top of the anterior wall, where the anterior wall is about to make a junction between say anterior wall and roof is making a junction, so there is a gap. In that gap, if you pass something through that gap, it's a very important gap again, and that gap is gone into the orbit. See, this is now orbit is there. In the orbit there is eyeball, bony orbit, which the eyeball is there. So in the anterior wall, I told you that right at the top, you will actually enter into the orbit here. That's why this fissure is called the orbital fissure, because this fissure is between what? This fissure now, you will see 3 questions now. It should be 4, but we can ask 3. Number 1, name, inferior orbital fissure. Number 2, location, this is present between, as a gap between the maxilla and the greater wing of sphenoid at the top of your anterior wall of the infratemporal fossa, and it communicates the infratemporal fossa with the orbit. Means many things from infratemporal fossa can pass through that fissure, can enter into the orbit. So you can go through this. So our 8th component, this time again in the anterior wall, is a inferior orbital fissure. This is again. So in the anterior wall, again I told you that alveolar foramina, at the top is the inferior orbital fissure. Posteriorly we don't have anything. Roof we have seen again 3, oval, spinosum, pterygoid fissure. Lateral side, mandibular foramen, mandibular notch, and nothing winding around the neck of the mandible here. So 3 here, 2 in the front, nothing in the back, and 3 in the lateral wall. 3 roof, 3 lateral wall, 2 in the front. 8 communications by now you have seen. Now you look at the medial side. When you look at the medial side now, in the infratemporal fossa, medial side 90% is formed by a muscle, which you cannot see in the dry skull. So that means 90% I say, which 90%? This whole 90, this one, this big gap which you are actually seeing, this one, this all is the muscle on the medial side. Now you have entered here, this all 90% is the muscle, but remaining anterior side 10% is this plate, this is bony plate, this is the bony plate, and that bony plate is also part of what? Part of sphenoid bone. Which part of sphenoid bone? That has actually emerged from the body of the sphenoid bone. And the body of sphenoid bone, one process emerges that we will see in the base of the skull, that is called the pterygoid process. And pterygoid process emerges like a big process here, but once it comes down here, here, it splits into 2 plates now. So that means it splits into 2 plates like here, like these 2 plates here. And from infratemporal fossa, if you want to see one of these plates, surely it will be the lateral plate, because there are 2 plates here. And if you are looking at one plate, this will be the lateral plate. And lateral plates also lateral surface, because you are seeing this here. This is called the lateral pterygoid plate. Of what? Of sphenoid bone. So this will be the lateral pterygoid plate. So most anterior part, if you are looking at your medial wall, you can't see posterior 90% at all, because this is smooth, this is the skeletal muscle, which is a skeletal muscle. Actually this skeletal muscle is the muscle of the pharynx that you will see here, pharyngeal muscle, and this is called the pharyngeal muscle. So that means if you will actually look at 90%, because this pharyngeal muscle takes origin from the pterygoid plates. So that means this is 90% is the pharyngeal muscle, which you can't see because it is no longer, but anteriorly 10% is formed here by the lateral pterygoid plate. So lateral pterygoid plate is the sphenoid bone. So this is lateral pterygoid plate. This is our medial boundary. You see, sir, is there any communication? Surely, because 90% already is the pharyngeal muscle. Means if the pharyngeal muscle is present here, you can say here is the base of skull and here is the pharyngeal muscle, because this is the top pharyngeal muscle, and this pharyngeal muscle superior border is touching the, touching the base of skull, but there is a gap. It is not really touching, there is a gap. If there is a gap, means above the superior border of your top muscle, top pharyngeal muscle, there is a gap, and if you are actually passing your hand through the gap, you are in the pharynx. Which part of pharynx? Top part of the pharynx, and that is top part of the pharynx which is lying behind the nasal cavity. That's why its name is nasopharynx. A very important communication from infratemporal fossa is passing through that gap, The gap does not have name, I think, but you see that is a gap above the superior, I say above the pharyngeal muscle. This pharyngeal muscle, because we have 3 pharyngeal muscles and these are the rounded muscles because they are in a rounded circle. One comes from one side, another coming from other sides, both will interdigitate in the middle to form the raphe. That is why these are called rounded pharyngeal muscles. Usually when they contract, they constrict. That is why these are called the pharyngeal constrictors. This was the top one, superior pharyngeal constrictor. Next one is called the middle, next one is called the inferior pharyngeal constrictor. So, this is called the superior pharyngeal constrictor. Means a gap between the base of skull, bony base of skull and the top surface, I say superior free border of the superior pharyngeal constrictor, there is a gap. Ninth gap is, you see that ninth passage is coming from infratemporal fossa is into the nasopharynx. And in the nasopharynx, who is going? You just remember, if something comes from your middle ear cavity through petrodium, very close to petrodiumbenic fissure, this is called the stretching tube or the auditory tube, and if it is coming here, it will go into the nasopharynx. And this is the way infratemporal fossa will be used for this. So, you say this is what we call here. So, ninth communication is in the medial wall. Above the superior pharyngeal constrictor, there is a gap. This gap will communicate you. This is not a foramen as such, but this gap is communicating the infratemporal fossa with the nasopharynx here. So, ninth communication will be this, you say above this level. I say told you that above the pharyngeal constrictor we have got this ninth communication is this. This is going to nasopharynx. This is going to the nasopharynx. Now, in the medial wall again, the 10th and the last and probably the most important here again. This will be present again in the medial wall. In the medial wall, this is your 90% is your superior pharyngeal constrictor, pharyngeal muscle, but anterior 10% is your lateral pterygoid plate. Lateral pterygoid plate, you know that is what? Lateral pterygoid plate is already is a part of the sphenoid bone, and we have told you that sphenoid bone and maxilla, they are not at good terms with each other. We have already told you that anterior wall was formed by maxilla, roof was formed by the greater wing of sphenoid, and sphenoid and maxilla, they don't talk with each other too much, they are a gap. And the gap, you pass the hand through that, it will come into the orbital. You call that inferior orbital fissure. Same thing will happen here. If this is the back of the maxilla, and here is the most interior part of your medial wall of the infratemporal fossa, this is called the lateral pterygoid plate, and lateral pterygoid plate, it is pterygoid, but he say that is terribly in relation to, it is a part of, the brainchild of the sphenoid bone, and maxilla and sphenoid bone, they are not at good terms with each other. So, he will actually ask him to stay away from me. Stay away means stay away, okay, he will request him that at least most inferiorly you just give me the fusion, superiorly I will stay away superiorly. So, that means if you are actually looking at this, so inferiorly they are used to make here, but superiorly mostly they are having here a gap, a fissure. So, between the lateral pterygoid plate of the sphenoid bone and the back of the maxilla, there is a big fissure here. Though inferiorly it is fused, at least this concession it has done, but you see already there is a very big fissure. Means in the medial wall, where you have already seen, here anteriorly we have got the maxilla, and here medially it was the pterygoid plate, and I told you that pterygoid plate inferiorly just 5% region it will be allowed to have a fusion, but then having here 90% there is a gap posteriorly by the lateral pterygoid, anteriorly by the maxilla. A big fissure is created, and that big fissure, because it is present between the pterygoid and the maxilla, that is why very simply it has been named as pterygomaxillary fissure. So, this will be our 10th communication, that is called pterygomaxillary fissure. A very important fissure in a sense that if you pass something through the pterygomaxillary fissure, you will come across a very small bony area where your wire will enter. And that area is yet another important fossa. It is such a small fossa that you can say it is a big room and a very small bathroom, you can say. It will like a small washroom in a very big room. A very big room is infratemporal fossa, and very small washroom. Through that fissure you will enter, that is the pterygomaxillary fissure. And that small washroom you can enter through this pterygomaxillary fissure, means without any door you can enter this through pterygomaxillary fissure in a very small room, very important, that is called pterygopalatine fossa. Means pterygopalatine fossa, if you want to access this pterygopalatine fossa from infratemporal fossa, the way to enter is pterygomaxillary fissure. And this pterygomaxillary fissure is our medial wall fissure, you can say. So in the medial wall fissure, most anteriorly at a junction between medial wall and the anterior wall, and anterior wall was the maxilla. And at the end of, you say, at the top of your anterior wall, and again the greater wing of the sphenoid, there is a gap, superior orbital, as inferior orbital fissure. Means now you can say this will be your 10th communication, 10th passage now from the medial side here. So in the medial side, 2 passages, superior to the superior constrictor and the nasopharynx, and then anteriorly you have already seen here between the pterygoid process and the maxilla, pterygomaxillary fissure into pterygopalatine fossa. Back side, styloid process, no communication. Lateral side, you see ramus of mandible, mandibular foramen, mandibular notch, and behind the neck of the mandible you have seen, you have 3 communications here. So 3, 2 will make 5. Anteriorly, maxilla, and the maxilla foramen are there, alveolar foramina, number 1. This is 6th communication. At the top, between the greater wing of the sphenoid, let's say roof, and the maxilla itself, there is a fissure. This is called the inferior orbital fissure. 2 more, it will have 7. And then in the roof, 3. 3 means foramen ovale, foramen spinosum, on the back side the prototympanic fissure. 3 more, 7, 3, 10. 10 communications within infratemporal fossa. If you have seen, this indicates that's the very important fossa. And these 10 communications are not just for fun, obviously they are for the passage of neurovascular bundles, just not actually sending them, but receiving many things also, like the veins and other things. And these identifications and all these things, in fact, when you will be doing, if you have got a good idea about this fossa, and then another class which we will actually conclude on pterygopalatine fossa, equally important, this may take more time even. This will be another fossa that will be here. You will win all these fossa, and when you will enter into the orbit, again you see 6 or 7 or 8 or 9, 10 communications in the orbit also. When all these things, and already cranial cavity, you will see too many of them. All these communications, when you see separately, and when you have got a good idea about them, then it will be very, very easy for you to in fact deal with the course of the neurovascular bundles here. Because you see, when small, if you bring out your any cranial nerve, it will be hardly 4 inches, and that 4 inches nerve actually has passed through say 5 to 6 regions. It will leave the cranial cavity, will pass through rotundum. I say, okay, it will leave the cranial cavity, middle cranial fossa, pass through foramen ovale, come into the infratemporal fossa. You have seen infratemporal fossa. If any nerve actually leave the infratemporal fossa, has gone into the inferior orbital fissure, it will enter into the orbit, 3rd, and from orbital fissure it will come here under the face, 4th. Means if you will get the nerve out, you see it has travelled through the middle cranial fossa, travelled through the infratemporal fossa, into the orbit, into the face. 4 regions it has actually travelled, and if you will get the nerve and will actually measure the nerve, it will hardly be 3 inches or maybe 2 inches. So you can actually see that all these regions, first you should identify and visit them. Do not count the structures. I am giving just an example for these structures will come, but you see that find these structures. So in any so first thing will be the skeleton and their fossa, their boundaries and their communications, how they are actually communicated. So first of all you will do your skull. Then I told you that in the skull you have seen the front of the skull, the top, the back, the lateral side, not the inferior side, okay, no problem, because in the inferior side already you have half you have done through the infratemporal fossa. So this will be, and then you see the cavities in the orbit, you see the orbit, the cranial cavity, infratemporal fossa, pterygopalatine fossa, temporal fossa, and then you see some other bones like hyoid bone and the vertebral column. And if all these things you will do in a proper way, then you will enter into the soft tissue. That will actually be dealing after this skeleton portion or the osteology portion, in fact, will be completed here. And it's not just the things on the board I am actually teaching you, but we will be discussing in a more elaborated way another part of this class of the infratemporal fossa through the projection, through some important pictures. And after the picture, the third thing that will be on the infratemporal fossa will be live on, you can say original skull.